Good evening, everyone. Thank you so much for joining us for our American Migraine Foundation webinar on migraine in pregnancy. We are going to have an exciting discussion with a great panel tonight. My name is Dr. Claire Sandoe. I'm a headache neurologist at the University of Toronto in Toronto, Canada, as well as one of the AMF editorial board co-chairs. And my fellow panelists tonight are Drs. Rebecca Burch and Andrea Harriott. Dr. Burch is a board-certified fellowship-trained headache medicine specialist at the University of Vermont Medical Center. She directs the Headache Medicine Fellowship there, as well as serving as an associate editor for the Journal of Neurology. And she has research interests in a number of areas of relevance to tonight, including epidemiology, prevention of migraine, and women's health. And Dr. Harriott, who is an MD PhD, is a neurologist at the Massachusetts General Hospital and an assistant professor at Harvard Medical School. She actually has dual subspecialty training in vascular neurology and headache medicine. She's done 2 fellowships, and she's a member of the board of directors for the American Headache Society, as well as the American Migraine Foundation. And again, she has some special research interests in the association between migraine and vascular disease in young women. And I'm really looking forward to hearing their thoughts on a topic that I think is really important and personal to a lot of people who live with migraine. As we go through tonight, we're going to start things off with a bit of a discussion, but please do put any questions you have into the question box, and we'll try to address as many of those as we can near the end of the webinar. So just to start with maybe a general question, is this something that is of importance to your patients? Is pregnancy and migraine something that many of your patients come and ask you about?
Well, I guess I can start. So first, I'm really thrilled to be a part of this webinar in pregnancy and migraine, and it is for the very reason that plenty of my patients are interested in this topic, and I do get quite a bit of referrals related to pregnancy planning, and many of my patients continue to see me during the course of their pregnancy as well. And so it is of interest to my patients, and many of the topics I think that we will be covering tonight will be informative, I think, hopefully for those that are listening, but in particular for the patients that come and see me.
Yeah, and I agree. Also want to echo the thanks for having us on. This is a topic that is of great interest to patients, and it's also a topic that I think is often challenging for people who treat patients with headache, because there is some uncertainty sometimes about safety, and therefore getting the word out there about the evidence that we have is of a lot of value to patients so that they can advocate for themselves as well. And we know from many survey studies and data from the American Registry for Migraine Research that concern about how migraine is going to change over the course of pregnancy is a factor in making decisions around reproductive planning for people with migraine, and that there's a lot of concern about how migraine treatment may affect pregnancy and affect the children as well. So I do think it's a topic that comes up a lot, and I certainly see this in my patients, and it starts even long before pregnancy even happens, as people are starting to think about reproductive planning in the future.
Yeah, I absolutely agree. This is something that is such an impactful decision to make, and so many patients come and wonder whether they'll be able to get pregnant in the context of migraine and how they'll manage both during and after. So hopefully we'll give some people some good information to help with those thoughts and plans tonight. So maybe just to start off, how common is migraine in people who are of childbearing age, Dr. Harriott?
Yeah, so migraine is actually quite common in those of childbearing age. Migraine is the second leading cause of years lived with disability, and it's a leading cause of years lived with disability in women in particular. And this is in part because migraine is more prevalent in women as compared with men. It can affect children and older aged adults, but predominantly affects women of childbearing age. So Migraine affects about 12 to 13% of the general population, but 18% of women, as compared with about 6% of men. So it's 3 times more common in women. And if you examine women of childbearing age, so we're looking, you know, somewhere between the ages of, if you just look between the ages of 20 and 40, and that's not fully expansive of women of childbearing age, but if you just look between those age ranges, we're talking about upwards of 25 to 30% or so of women that will experience migraine. And even if you look post-puberty, there's a gradual increase in the prevalence of migraine post-puberty in males, but a real sharp rise in the increase in prevalence of migraine in females. And so what we're really talking about here is that in females of childbearing age, there is a significant impact of migraine on that population. And we know that it can affect everything from social interactions to pregnancy planning and family planning, as was mentioned, because of the high prevalence.
Mm-hmm. And can you tell us something about the hormone changes that might be seen as people become pregnant and how that might impact migraine?
That's a really great question, and it's a question that I get quite often. So if we think about how there's this sharp rise in the prevalence of migraine around the pubertal period, it speaks to the fact that hormone changes may influence the disease itself and how it actually presents. And so we believe that hormones, particularly hormone changes during pregnancy or in and around pregnancy, may alter the way that migraine presents during pregnancy. And there have been a few studies that have looked at migraine around pregnancy and that have demonstrated that in some people there may be a reduction in the frequency of migraine around pregnancy. 50 to 80% of patients may notice a reduction in their migraine around the 2nd or 3rd trimester of pregnancy. This tends to occur in patients that have a diagnosis of migraine without aura. But many patients in the 1st trimester of pregnancy may still experience migraine. This reduction in migraine during the 2nd and 3rd trimester, and for some people even remission of migraine during the 2nd and 3rd trimester, may be related to alterations in hormones that occur during pregnancy. So an increase in circulating estrogen and a stabilization of estrogen during the course of pregnancy may account for this reduction in headaches, in migraines specifically during the 2nd and 3rd trimester. So we do see some hormone changes that occur during pregnancy. We expect to see hormone changes during pregnancy, and that in fact may impact a migraine frequency and even remission of migraine. But that may occur in 50 to 80% of patients, and predominantly in those that have migraine without aura. You can also see new onset migraine though during pregnancy. So not everyone experiences this reduction or remission, and that's important to note that not everyone experiences that.
It does sound hopeful though, the numbers in terms of how many people are likely to feel better in pregnancy. That sounds like a helpful thing to tell people when they're wondering what migraine will look like for them. Dr. Burch, is that your experience too, that people often will feel better in pregnancy?
Yeah, most patients do get better after the 1st trimester, as Dr. Harriott said. I think the ones who don't get better are the ones who we often tend to see much more frequently in headache clinics, certainly, and I think we're going to talk about treatment in a little bit, but I do think the good news is that most people are going to get better.
I've had patients come back and tell me that it was the best time of their life when they were pregnant from a migraine perspective. not everyone, as you've said, and so we'll certainly talk around some strategies there. Any difference in the way that migraine attacks themselves look, or triggers, or things that are different for people to experience during pregnancy?
That's a great question. I mean, certainly patients may experience some different or unique triggers during the course of pregnancy. They may experience alterations in sleep. They may experience nausea during pregnancy, particularly in the first trimester, which is important to treat. They may experience changes in hydration and dehydration, which is important to address. So all of those things, alterations in sleep and eating habits and hydration or dehydration, are very, very important to think about during pregnancy as potential triggers that may occur during pregnancy. Also stress, right? Both positive and negative. All of those things may also come into play during pregnancy, and it's important to talk to patients about how they're managing the anticipation, both things that they may be worried about or things that they're positively anticipating, and how that may impact their migraine frequency as well. What is important to note is we shouldn't be complacent about migraine attacks occurring during pregnancy. So in patients that are seeing new migraine that is different from their prior migraine headache, or they're experiencing new symptoms or an increase in frequency as the pregnancy progresses, we do have to be concerned about the possibility of other conditions that may also occur during pregnancy, like preeclampsia or eclampsia. We do not want to miss those other conditions as well.
And how commonly do you see things in terms of this change in pattern, things like new aura during pregnancy?
So new onset aura, so we mentioned that it is possible to develop migraine for the first time during pregnancy, and it is possible to develop a new migraine with aura during pregnancy. It happens infrequently, but it is possible. There is some data to suggest that estrogen or increasing estrogen may increase the risk of developing migraine with aura. So it is possible that an aura attack can occur as new onset, even in those that have an existing history of migraine without aura during pregnancy.
Maybe before we shift gears a little bit to treatment, just one more question about what to expect during pregnancy. How do you counsel women who are pregnant about pregnancy outcomes and migraine? Should they be worried about what will happen to their babies? Are their babies at risk for anything specific if they have migraine and they're pregnant?
So that question is one that I often get patients referred to my clinic because of the intersection that I have in terms of my subspecialty training between vascular neurology and headache disorders. So there have been several studies that have looked at pregnancy-related outcomes in patients that have a diagnosis of migraine, and in particular migraine with aura. And those pregnancy-related outcomes can be anything from preeclampsia to other outcomes, including low birth weight and things like that. What I will say is, while there is an association between migraine and these other pregnancy-related outcomes, the absolute risk, I think, it still remains low. And so I think that in general, those that have a diagnosis of migraine should not be worried about pregnancy or pregnancy planning. I think that they should remain knowledgeable about signs and symptoms that one should be concerned about or that should raise their attention. And if they do have questions, they should certainly ask their provider about those questions that they have so that they can discuss them and allay those fears. But in general, the absolute risk of preeclampsia, of early delivery and things like that, I think the absolute risk is low. But certainly there is an association between migraine and these outcomes.
So again, I guess it sounds really hopeful. And just to mention for our audience, there are some great resources on the AMF website to read more about things like what would be worrisome signs or symptoms, and a tool to help you find a healthcare provider who's a headache specialist if you don't currently have one. So maybe we will switch gears to some other topics that I'm sure are of great interest to our audience. So we're going to talk about some treatment options, because this is something that there's a lot of buzz about what's safe, what's not safe, what can you do and not. So Dr. Burch, what's your general approach to somebody who comes and says, what is it that I can take when I'm pregnant?
Yeah, so I will just say off the bat that this is a very large topic because, migraine, when, even when someone comes in for a migraine treatment plan when they're not pregnant, we're often thinking about acute treatment and preventive treatment and non-pharmacologic treatment and a rescue plan, and all of that carries into pregnancy, and we just kind of modify it. So I'm going to try and break it down a little bit in terms of how I think about approaching treatment in a patient who is either pregnant or is planning on becoming pregnant. I'm always really happy to see somebody in the pre-pregnancy planning stages, because we can start to talk about what things are safe, and also to put in place any kind of lifestyle modification that can happen in terms of improving sleep, working on hydration, regular meals. And before pregnancy is also the time to start practicing things like mindfulness meditation, biofeedback, any of those things that involve having a bit of a learned relaxation response. It's always nice to be able to have that ingrained before pregnancy even happens, because early pregnancy is often not a time when people feel like doing a lot of like new kinds of things. So really getting all of that non-pharmacologic stuff in place beforehand can be really helpful, and that is also what I really try and stress during pregnancy as well. And then I think about whether this is somebody who needs prevention. And some people do decide to stop prevention before starting pregnancy for the reasons that Dr. Harriott mentioned, particularly that people do tend to get better over the course of a pregnancy. And so they may decide to try and get through that first trimester without preventive treatment, particularly if they have tried a number of things already and the things that have worked for them are things that we prefer not to use, and in that situation they may just try and get through. Or sometimes we change things that are less preferred to things that are more preferred in anticipation. And then always optimizing acute treatment. So when we talk about preventive treatment in pregnancy, this is actually, I think this is what you were alluding to. The guidelines have actually changed in this area a little bit recently. And I think it's an area of a little bit of controversy in the headache world right now, because the American College of Obstetrics and Gynecology, ACOG, came out, I think 3 years ago now, with a revised set of recommendations about the safety of preventives in pregnancy. We used to recommend things like propranolol as a very high level recommendation because beta blockers are often used for management of hypertension in pregnancy. And so we kind of borrowed that and used that for preventive treatment of migraine as well. But in the updated guidelines, ACOG actually prefers calcium channel blockers to beta blockers. So things that fall into that category are things like verapamil, nifedipine, and amlodipine. And we historically don't use those so much for migraine prevention, but in the new guidelines that are coming out from the American Academy of Neurology and American Headache Society, nifedipine does have some evidence for benefit for prevention. So I think, there's a lot of discussion going on right now about whether beta blockers or calcium channel blockers should be preferred as first-line preventive treatments. And we'll see that kind of sorted out in the next couple of years. I am on board with calcium channel blockers. Dr. Harriott, what's your opinion?
Yeah, I would agree. I do think that calcium channel blockers can be used, and I'm also on board with it as well. And also, there are, we oftentimes say that, the beta blockers are safe or 100% safe. That's actually not completely the case, because you can see low birth weight related to the beta blockers when given during pregnancy. So low birth weight of the baby. So I'm also on board with the calcium channel blockers, and for some patients that have migraine with aura, people have been using calcium channel blockers for prevention, and continue to use calcium channel blockers for prevention, and have seen some efficacy there. So I do wait with anticipation the recommendations that will be coming out shortly.
Yeah, calcium channel blockers are kind of an interesting situation in preventive treatment in general, because a lot of us do use them, despite the fact that there isn't a lot of evidence in the literature, just based on a lot of us having a good experience with them in clinical practice. So I think that also, for many of us, makes us feel more confident in using them as a higher up in the list of preferred preventive treatments in pregnancy as well. So that's kind of what's a good choice. And then if we kind of go down the list, I think propranolol's there. Tricyclics like amitriptyline are kind of next in the list as well. Another treatment in pregnancy that has been a little bit controversial and is really interesting is the use of onabotulinum toxin during pregnancy, which historically people have been less comfortable with, but is actually, again, starting to move up in the list of comfort as we have a little bit more evidence. And it's been very interesting to me to see how quickly people who treat pregnant patients with migraine have adopted using onabotulinum toxin in their patients during pregnancy. And that's really just was one of those things where kind of everyone was thinking about it, and then everyone started doing it. And now there's just a lot more comfort. And the ACOG guidelines actually support that as well. Onabotulinum toxin A is actually on the same level as propranolol in terms of safety. So that's kind of an interesting thing, and another place where I think we're going to see things really kind of hashed out over the next couple of years. In terms of what to avoid for preventive treatment in pregnancy, the big one to remember is that anyone who is on divalproex or valproate should not be on that during pregnancy. It has a lot of potentially adverse effects on babies born to mothers who take it during pregnancy, including intellectual disability, other developmental disorders, and things like that. So it's a real just non-starter, so people should not be on that during pregnancy. Topiramate is also not a great idea because it increases the risk of cleft palate and cleft lip in babies born to mothers who take it during pregnancy. And right now, we don't have enough evidence about CGRP monoclonal antibodies or other CGRP targeted treatments. And so the recommendation now is to avoid using them, although we're starting to see a little bit of evidence trickle out. It's not very great quality evidence. So far, there haven't been any major safety signals. I can say that pregnancy registries are being sponsored by the manufacturers of these treatments, and anyone who is exposed to these treatments during pregnancy should go and be a part of the registry to kind of contribute their experience and their data, so that 5 years from now, maybe we will have more evidence and be able to make a more educated decision about whether to use these treatments. So that's kind of the preventive piece of things. And then I just wanted to briefly talk about acute treatment as well. There are fewer classes of medication, so it's a little bit of a shorter discussion. The things that I really want people to remember are that triptans appear relatively safe in pregnancy according to the evidence that we have. And I know there's still a lot of hesitation in some, some people hesitate to prescribe them during pregnancy, but they're actually probably the best studied treatment in pregnancy that we have. They have done studies looking at the safety of triptans during pregnancy in entire countries worth of data, Scandinavian countries in particular, which have wonderful record keeping and are able to tie a lot of different information together. And as Dr. Harriott said, migraine itself can increase the risk of some adverse outcomes in pregnancy, but triptans do not increase that risk. The one thing that we may want to be concerned about is if a patient does have something like gestational hypertension or preeclampsia, or if they had that out of the previous pregnancy, or if there's any concern about how well the baby is growing or the placenta development or anything like that, those would be reasons why we would want to avoid triptans. But I generally feel pretty comfortable continuing them, especially if nothing else works for somebody. And we avoid a lot of other things in pregnancy. So that's, I think not a lot of people necessarily know that triptans are maybe a little more, could be used more widely than they are. Gepants right now, things like rimegepant and ubrogepant, we just don't have enough evidence. So we generally recommend avoiding those. And then NSAIDs are the other big category of things, and they are probably okay to use in the second trimester only. In the first trimester, there's some concern about whether they increase the risk of miscarriage. In the third trimester, there's a risk of patent ductus arteriosus, which is a kind of a fetal heart condition. But in that second trimester, maybe it's okay to use them. And then the other big thing that I'm really interested in watching over the next several years is whether we start to recommend aspirin for our patients with migraine, because daily low-dose aspirin is recommended for any patient who's at high risk of vascular outcomes, hypertension. I think it's anyone over the age of 35. Dr. Harriott may know that better than me. And because migraine does increase the risk of some of these outcomes, I'm really interested to see whether we end up making the recommendation that migraine is one of the reasons we might want people to take aspirin. So that's kind of a, kind of a broad overview of my approach to treatment in pregnancy.
Thank you. It sounds like there are lots and lots of options that you have in your toolkit, and I wanted to highlight one of the things that the themes that came back a couple times as you were talking, which is that we are always doing more studies, we are always learning, we're always trying to find new and better options for people. And so the answer that you get today may be different than the one you get a couple years from now as we learn new things. All of these decisions are individual, and so what's comfortable for you and your provider may be different than for somebody else and their provider, which is okay. But it's good to find somebody who you trust to help have that conversation. Dr. Harriott, any other thoughts about your approach here?
Yeah, I think I think it really mirrors a lot of what Dr. Burch has said. And one of the things that I just wanted to mention was, it used to be that we would only think about Tylenol or acetaminophen and metoclopramide as go-tos during pregnancy for abortive treatment, and I think that our thought process is changing in terms of allowing patients to be able to adequately treat their migraine attacks with migraine-specific medications in the form of triptans. And I think that does really help patients in not only the ability to be able to use medications that have worked for them effectively outside of pregnancy, but in understanding that they actually do have a medication that they can use so that they don't feel fearful that if they have an attack, that they're not going to be able to adequately treat it. And I think that that's really, really key. I think that that's important. And I was wondering from Rebecca, what are your thoughts about acetaminophen, metoclopramide combos? Do you have do you use that over a triptan, or do you start with a triptan? What are your thoughts? Because oftentimes I would hear do the acetaminophen metoclopramide combo first before doing a triptan, as opposed to continuation of the triptan.
Yeah, that's a really good question. And I do often try acetaminophen and metoclopramide in combination before going to a triptan. And that's particularly the case if someone is having attacks that are less frequent or less debilitating. So if I feel like the consequences of not fully treating or treating successfully are a little bit lower, I think if someone has very severe attacks, particularly if they're associated with a lot of vomiting or disability, or they tend to be prolonged if we don't get on top of it right away, and we know that triptans work for that person, that makes me maybe a little bit more likely to keep going with the triptans. But yeah, I do often try acetaminophen and metoclopramide first. And I think you're bringing up acetaminophen actually raises another important point about an area of controversy, because acetaminophen, I know many of us feel very comfortable using it, but there was some concern raised a couple of years ago about acetaminophen potentially increasing the risk of developmental disorders such as autism in children born to women who take acetaminophen during pregnancy. There was this big paper with 95 authors or something, saying that there was a call for concern. But the difficulty with a lot of those studies is that they can't separate out the use of acetaminophen from the reason that the person is taking the acetaminophen in the first place. So it's confounding by indication, and they didn't do a great job necessarily of separating that. And the other issue is that the risk was highest with prolonged high doses, prolonged use of high doses. And so at the end of the paper, their recommendations were to use it only if needed and to use it at the lowest effective doses for the shortest time possible. And I don't know about you, but that's what I do with everything anyway. So it doesn't really change my practice. And ACOG did not really change their feelings about acetaminophen either. We still use it. So yeah, I think that's a really good point to bring up. The other thing that I forgot to mention that I just wanted to throw in here as well is the possibility of occipital nerve blocks during pregnancy, which not every neurologist or headache specialist does, but for those of us who do, occipital nerve blocks can be a really nice option as well, because lidocaine is considered safe in pregnancy. It's the same stuff that you get if you have to have a tooth filled at the dentist, which certainly many people do during pregnancy. And we can do nerve blocks, once every month, once every 6 weeks, whatever is needed to get people through. And that can be a really nice treatment, especially in that first trimester when we're hoping things get better and we're just kind of trying to get people through the next couple months.
Yeah, I have to say nerve blocks are one of my very go-to options, also because they're easier to start and stop, and sooner if they're helping. And then especially for people who are in that limbo while trying, sometimes if you're not sure how long it will take for someone to get to that more nice pregnancy stage of doing better, sometimes that can be a good option if there's access. I did want to ask, do you have preferred pregnancy triptans, Dr. Burch?
I don't. I typically go with either sumatriptan or niratriptan, just because they are the ones that were best. They're the most commonly used, so those are the ones that we have the most data available for. Again, in those large registry studies, or the population-based studies, and in the registry studies that we have, sumatriptan is the one that comes up most often. So that's what I tend to go to. But again, there's no theoretical reason to believe that the short-acting triptans are going to be different from one another from a safety standpoint. So if one of them I know works better for a patient, I'm usually willing to continue it.
And at what point, if any, do you bring neuromodulation into the mix?
That's a bit of a tough question. People have a lot of different feelings about neuromodulation. I think it's always reasonable to try, and I think it's unlikely to be harmful in pregnancy. I can't really think of a theoretical reason why it would be harmful. And one study, the remote electrical neuromodulation device for acute treatment, did actually have a pregnancy safety study that was done retrospectively by a group, I think in California, and it looked good. So we do have some evidence for that one in particular. So I think if patients are interested, I'm always happy to support that. The difficulty is that these treatments are sometimes not covered by insurance and they tend to be expensive, and I am always hesitant to recommend a treatment I know is going to be expensive for a patient, and that's my major barrier.
And so we've got some good options in the mix here. I know you've gone through a lot of the medication procedural kinds of things, but we haven't touched so much on some of the nutraceutical kind of vitamin strategies. Is that something that you often build into plans around pregnancy?
Yes. This is another one of those things that I think is kind of an interesting area of discussion. So magnesium has historically been used very commonly as a first-line preventive treatment in pregnancy. And you'll still see a lot of neurologists and a lot of headache providers using magnesium and feeling very comfortable with magnesium. And I'll be honest, I do too. And for full transparency, I took it during both of my pregnancies, and I guess you can't get a more like vote of confidence than that. But magnesium, it's not quite as straightforward as it seems, because IV magnesium and longer than 5 days in a row, which is a treatment to stop premature labor, was shown to have adverse effects on fetal bone development. So basically the magnesium at high serum concentrations displaces calcium in the fetal skeleton. And for that reason, use for longer than 5 days was considered, back in the day when they had pregnancy categories, it was a category D, which means that you should not use it unless you really have to. And because of that, and the FDA never clarified whether that change in safety categorization should apply to oral magnesium as well. And so now you get this debate where people say, well, but the studies we have never showed any problem with bone development in people who take magnesium, but all those studies were done before we knew this was an issue, so they didn't look. And so you get this, kind of debate back and forth about whether it's safe and whether it's not. My personal take is that magnesium is not very well absorbed through the GI tract. And the chances that you're going to absorb enough magnesium, from an oral route to get high enough serum concentrations to outcompete calcium, in the fetal skeleton is like vanishingly low. And so I feel comfortable using it, but I don't think it's quite as straightforward as it used to be. So I do sometimes have this discussion with patients if they ask me about it. The other things really haven't been studied. So vitamin B2 has not really been studied at all at the kind of supraphysiologic doses that we use in pregnancy. I should say that both feverfew and butterbur should be absolutely avoided during pregnancy because they increase the risk of miscarriage, both of them. So those are non-starters, and some combination supplements like well, I don't want to give brand names on this, but there are a number of branded combination supplements that have herbs in them, like feverfew or butterbur. And so if you're taking one of those, you have to read the label and make sure that you don't have that in there if you're pregnant or attempting pregnancy. But I don't have an issue if people want to take magnesium and vitamin B2 during pregnancy.
And do you counsel people about things like vitamin D, folic acid?
I don't do a lot of that. I mean, I think folic acid is generally covered by most, either primary care or OB before they even get to me. The recommendation, I think, for all pregnant people is to take folic acid. So yes, absolutely. If someone's not, I will call that out and make that recommendation. I don't talk a lot about vitamin D. Where I am, I'm in a very northern latitude, and we talk about vitamin D all the time with everybody all the time. I don't know if it's like that. I guess we're all practicing in pretty
Way up
northern
north.
parts of North America.
Vitamin D. Yes. Dr. Harriott, anything else you wanted to add? Your go-tos for treatment?
Yeah, I mean, I think just from the non-pharmaceutical standpoint, I would completely agree in terms of magnesium that I don't think that we use doses sufficient to displace calcium and produce bone problems, but in patients that are going into the emergency room where they may be getting intravenous magnesium for abortive relief, I think there we might want to think twice about that strategy. If you're doing it from home via oral route, I think it's not much of a problem, but if you're doing it in the emergency room and you're thinking about administering magnesium for abortive relief as part of some cocktail, I think there is where one might want to be concerned. And then in terms of the devices, I think that it's a ripe area for additional research, whether it be, just collecting evidence from patients that are using the devices during pregnancy to understand any risk associated with them. I think that it is an opportunity for us to just understand better what the efficacy is, what the device is, and whether or not it impacts outcome in any way. And the reason that I say that is because for some of the devices, we do understand that the role is for neuromodulation, but across what neural circuits for some of the devices, we're not quite sure. And so, for example, if it releases endogenous neurohormones like oxytocin, which we know can provoke uterine contractions, we might want to know that if it's related to a particular device. But we don't want to put the devices at any disadvantage to pharmaceutical agents, which may also carry risk as well. So I think the devices are relatively safe, and I too have patients that have used devices. But I also counsel patients that we have relatively little evidence of their safety profile in pregnancy.
Great. So maybe we'll switch gears one more time, and we're going to talk about lifestyle. Is this something that we should talk about or focus on in pregnancy or not? Because this is something that I get asked a lot. I'm sure you do too. What is it that I need to do in my life to make this better? So what do you tell people about their diet and lifestyle in pregnancy? Maybe Dr. Burch first. All right, Dr. Harriott, go.
No, Dr. Burch was gonna answer.
Okay. So I just want to preface this by saying that I'm always careful when I talk about lifestyle with patients, because there's a line between providing education and giving a sense of self-efficacy and making people feel responsible for having a migraine attack if they don't do everything right. And you don't need that in your life. So I always the things that I really emphasize are, again, trying to get good sleep to the extent possible. Hydration is the biggest thing. Many people who are pregnant, whether it's, in the early stages of pregnancy, there can be decreased appetite, there can be nausea, that kind of makes it hard to get good fluid intake. And often later in pregnancy, the demands for fluid are so high that it can be difficult to just keep up with the amount of fluid that's needed. So hydration is just such a big point of emphasis for me. Maintaining good physical activity if you can. I mean, that's always such a challenge in people who have migraine because it makes it worse. And so, you basically want to just try and support to the extent possible, just moving your body. I'm a big fan of like prenatal yoga, things that are a little more gentle, and you definitely not the time to like take up a running program if you didn't have one before. And I do think making sure that family support is there and in place. It's a really, we don't talk about this very often, but pregnancy is actually a really vulnerable time in a lot of pregnant people's lives. And so we want to just make sure that the home situation feels safe, that it's a good situation, they're getting the support that they need. And so I always kind of do that assessment and just checking into mental health and how all that's going for them as well. So those are the things that I tend to focus on.
Yeah, and I'll echo some of the same. I think a lot of what I tend to focus on are things that I can also help with for my patients. So for example, if my patient is experiencing a lot of nausea, then I try to think about ways that we can help with that. If it's through changes in nutrition, sometimes they want to talk about things like ginger. Will ginger help? Or if they want prescriptions for things like metoclopramide, if that might help. We talk about how they might be able to change their sleep hygiene or what things are impacting their sleep hygiene. We do tend to talk about stress and stress management, but I feel like that is usually something that we start before pregnancy planning. And one of the things that I think is important to talk about is having that initial discussion with my patients. So for a lot of my patients, I try to have a discussion fairly early on and check up with them about when they're starting to think about it or if they're starting to plan. And I think it opens up a lot of for my ability to be able to understand, whether or not my patients are thinking about pregnancy planning prior to them becoming pregnant. And then hopefully we can start to think about ways in which they can mitigate a lot of issues that may come up during pregnancy, and to have sort of a plan for pregnancy when issues arise, so that they feel more empowered during pregnancy as well. And like Rebecca mentioned, I mean, you're not going to be able to be perfect at everything. So a lot of it is also reassuring patients that not everything they do will increase or decrease their migraine headaches, so that they don't always feel responsible for every migraine that they have. And I think that that's really important for patients. So it is important to talk about lifestyle and lifestyle management, but also not to make it so that it becomes a stressful time, so that they can actually enjoy their pregnancy. And so a lot of it is also touching base with what I can do to help them through whatever lifestyle strategies they want to enact during pregnancy.
I think the point that both of you have now made is a really great one, that trying to implement some of these things in advance of pregnancy, if possible, is much more likely to be successful. But they also like to tell us that quite a lot of pregnancies are unplanned. I think the number that we're often told in med school is 50%. And so always good to have that conversation with your provider well in advance of anything happening, whether it's planned or unplanned, so that whatever happens is well supported and people feel as comfortable as they can going through pregnancy. And maybe just before we move to the question period, any last pearls of wisdom that either of you wanted to give to anybody about migraine and pregnancy? Dr. Harriott, are you up for going first for this?
Yes, I can give pearls. So a few things. I would say that reach out to your headache medicine specialist. I find that at least for me, I want to be engaged in that discussion and that process. We have plenty of ways to be able to manage headaches and migraines during pregnancy and around pregnancy. I don't think that it has to be a time of fear or anxiety for patients. We can come up with a plan to support patients if they're going to do it naturally or through in vitro fertilization. I think that we can plan around it. And so I think that making a plan with your headache medicine specialist, asking questions, even if it's just asking questions, is really important. So if you want to just sit down and say, hey, I just want to have a visit just to talk about pregnancy planning, I think that it's worthwhile, because we do find that for migraine patients that they can delay pregnancy related to fears associated with the timing of discontinuing medications, the fear that their migraine might impact their pregnancy and fetal outcomes, and also that their headaches or their migraines might increase in frequency. And so having that discussion with your headache medicine, with your migraine specialist or your headache medicine specialist, I think will help to allay some of those fears, or at least address them, and come up with a plan to figure out how to manage through some of these issues.
Dr. Burch?
Yeah, I echo that. We're going to be here with you, and that is the one thing I always say, and I think that's actually kind of the most helpful thing, is you're not going to be alone. We're going to be here with you. We have all these things we can do. You're going to get through it. It's going to be okay. And I really always ask routinely about, pregnancy planning in a very non-judgmental way, because there are lots of people who never want to be pregnant. And so we don't want to make the assumption that that's going to happen. But I do try and make it kind of a routine part of getting to know somebody so that I can kind of think about things down the road. The other point that I just wanted to say is that, as you mentioned, 50% of pregnancies are unplanned, and often people are on all of these medications that we say are not a good idea, at the time of pregnancy, and it happens despite all our best efforts. Someone will have an IUD in place, at the time that we prescribe something, and then they come back 4 months later and they're pregnant on something that we thought was okay, because we thought they had an IUD, and in the interim it came out and we didn't know. So these things happen, and we are talking about increased risk, but we're not talking about certainty. And so I also just want to reassure people that if it happens, despite everyone's best efforts, it's probably going to be okay. So don't panic. That's my big lesson. Don't panic.
Don't panic, we're here with you. I think those are great thoughts to close our discussion, but there are a lot of questions, so we're going to do our best to get to as many of these as we can. A couple of these actually segue really nicely with a couple of things that were just said. So in terms of just these medications that we think are maybe suboptimal while you're pregnant, there may be two parts of the question here. So how long would you ideally stop some of those non-recommended medications for before you start trying for pregnancy in an ideal situation?
So it depends on the medication. If it's an oral daily medication, the half-life is probably quite short. So the half-life is how long it continues to, it's a measure of how long it continues to circulate after you stop taking it. And the longer the half-life of a treatment, the earlier before pregnancy you should stop it. But a lot of the medications that we use as daily preventives have relatively short half-lives. And honestly, if you, like, for example, we're doing like an egg implantation, so you like knew the exact day that, hopefully pregnancy was going to happen, you could stop taking it 24 hours before that and it would be fine. And it even then takes some time for the maternal part of the placenta and the fetal part of the placenta to even link up, so medication transfer to even happen takes some time. So for short-acting things, you don't have to stop very long. You may want to, so that you know what's going to happen, and if things get much worse, then you have an opportunity to make a backup treatment plan. For things like onabotulinum toxin, you typically want to wait. You want to do the last set of injections, if you're stopping it, 12 weeks before anticipating trying for pregnancy. And if it's a CGRP monoclonal antibody, which has a half-life of 28 to 30 days, we try to allow 5 half-lives, so that's about 5 months. So doing the last injection about 5 months before trying for pregnancy.
And the follow-up question to this is, what do you do in that time while you're off these medications and you're trying to get pregnant?
Right. Well, Yeah, and this is the tough part of things. That is the hardest part. So that's where we think about nerve blocks. That's where we think about potentially trying medications that are safer. So that might be the time that you're going to start your calcium channel blocker and see if it works for you. And it may also be that in some people you do want to just kind of, run the treatment much closer to when you anticipate trying for pregnancy. But the hardest thing is somebody who's on a CGRP monoclonal antibody and they're going to stop it, and then we're looking at a gap of like 4 months. And in that time, that's the time that we're going to try, oral preventives that are, like I said, safer in pregnancy, or we're going to do nerve blocks, or, we're going to try some other things in that time frame.
Yeah, I would completely agree with that. I think that comes up mostly as a question with some of the monoclonal antibodies, and there are sometimes I switch to orals with the same, target mechanism, or target, maybe we switch to other injectable agents that can be used up until the point of pregnancy, so that there's not this gap. So that's one possibility. To do it. Other people, we might do a trial to see if off the monoclonal antibody, patients have a period of time where they have a lower frequency of migraine. Some patients do have this period of time of a lower frequency. Some patients don't, and they know they won't because they have an increase in frequency just before the next injection. So it really does depend on the patient and what their migraines are like.
And just on that nerve block note, there was a question about how often you might do them. I know my practice is often something like 4 weeks and not necessarily more frequently. Do either of you do them more frequently, less frequently in this context?
I tend not to do them more frequently than 4 weeks. I do know of people that do them more frequently than that, but you can get alopecia, nerve block related alopecia and things of that sort. But I tend not to do them more frequently than 4 weeks. But Rebecca, I don't know, do you do them more frequently than that? Yeah.
No, 4 weeks. 4 weeks. I worry a little bit about developing scar tissue if you're just repeatedly sticking a needle in there. So yeah, I think 4 weeks is my limit too.
I also wonder if people sometimes lose duration of benefit if they're being done very often for prolonged periods of time. But speaking of procedures, sphenopalatine ganglion blocks, is that something that either of you do around pregnancy?
I don't do them, so I don't have any insight into that for you. I mean, I think as long as they're using lidocaine, they're probably okay, although they feel a little riskier to me because you're starting to involve autonomic pathways. So I don't have a lot of insight there.
Same. I tend to mostly do occipital nerve blocks and maybe other more peripheral nerve blocks, but I don't tend to do sphenopalatine ganglion nerve blocks.
Okay. Here's an interesting question on a non-treatment topic. Are there differences in migraine depending on the sex of the baby? Someone is noting that they did differently in a pregnancy with a son than a daughter. Is that something that either of you have seen or heard?
No.
It's a fascinating question. We're going to have to do some studies about this, I think. I have to say it's not something I've seen. I do sometimes see, the first pregnancy may not be as difficult as the second, for example, and that they're not always predictive of how the first pregnancy being good doesn't necessarily mean the second one will be good, or the first one being tough doesn't necessarily mean the second one will be tough. But I don't have any knowledge here. Sounds like this is an area that we need to do some studies.
Yes, it does. I would not be able to rule that out as a possibility, but I don't know that we have clear evidence of that. Yeah, it's a great.
And I think that's one of the general points. We're still working and trying to study and get better options for all of our patients who are living with migraine in pregnancy. And so I think that's about all the time we had for questions. Thank you so much for all of the really wide-ranging, interesting questions that were submitted. And thank you so much to Dr. Harriott, Dr. Burch for the thought-provoking really interesting discussion, and please stay tuned. This webinar will be posted on our website, and as mentioned, we have a number of great resources for reading more about migraine in and out of pregnancy, as well as helping you hopefully find a healthcare provider who's a headache medicine specialist. And we appreciate you joining us. Have a great evening.